Okay. Just kidding. All right. Hello, welcome everyone. Welcome to the COVID-19 ECHO series, learning series for the Mountain States. We'll be offering a bi-weekly learning conference every other Tuesday morning at 7:30, from 7:30 to 8:30. So we welcome you to forward the registration link to your colleagues. Or anyone else who would be interested in attending. Today, our speakers will be covering therapeutic options to treat patients with COVID-19. Our topics will change every session, so do come back every 2 weeks for a different topic. Before we get started, I wanted to point out that this is a collaboration of the National Emerging Special Pathogen Training Education Network, the NETEC, Denver Health, and the Denver Prevention Training Center, and the Robert Wood Johnson Foundation. So welcome and thanks for joining us. My name is Sarah Rowan and I'm one of the infectious disease doctors at Denver Public Health. Over the next few months, we're hoping to increase knowledge of COVID-19 over a variety of subjects, including treatment, testing, pathophysiology, respiratory management, and infection prevention, among others. So today we'll start with Tech Check, which Victoria is going to walk us through.
Thank you, Sarah. Good morning, everybody. I see some of you are on camera, so we want to first thank you for those of you who are on camera. If you are not on camera, we would love to see your face. It makes it much more interactive and it makes the discussion portion much more smoother too. But I want to point out a couple of features of Zoom. So down in your lower left corner, you're gonna see an unmute little microphone. If you wanna pose a question during Q&A, you're welcome to just click that and unmute and ask a question. We just ask that you stay muted during when you're not speaking, just so we avoid that background noise. Next to that is the start video, which again, we would love to see you all. So please feel free to click that so that we are able to see you during today's session. And then I want to point out our chat feature. So if everyone could chat in where they're calling in from today, just to make sure you know where the chat is and you're able to put your questions there. So when you have questions throughout the presentations today, you are welcome to just put them in there and we will answer those during Q&A at the end. We have dedicated time. And then the last thing is up in the top right corner of your screen, you will see a gallery or speaker view. So either look kind of like a waffle or like an old school video camera thing. You can play with those. One, the speaker view will have whoever's talking the biggest on your screen. So if you have that right now, you see my face the largest. And then if you have the little waffles or Hollywood Squares, Brady Bunch, whichever you want to call it, you're going to see everybody at once. So with that, I will turn it back over to Sarah.
Okay, thanks, Victoria. So looks like a few people are still coming in. So the next part, what we'll do is a quick set of polling questions, and Victoria will put them on the screen. You can put your answer in there, and we only have just 3 questions just to kind of set the stage for what we'll be talking about today. So go ahead and put your answer in here. Victoria, do we get to see the summaries?
Yes, I will display those.
Okay. So you kind of anonymously put your money down. Okay. And then we will go to the next polling question, which is, true or false, remdesivir is an approved medicine for the treatment of COVID-19.
We've got about 60% of people.
And, okay, true, false. And then we'll do the last polling question before we get started with our speakers. So patients discharged should continue dexamethasone to complete a 10-day course. This comes up a lot in the hospital.
Like 50-50 split.
Okay, all right, sounds like there's hopefully something to learn today. So today we'll be covering remdesivir and dexamethasone, and then we'll be talking about convalescent plasma. So our first speaker is Dr. David Wiles, who's Chief of Infectious Disease here at Denver Health, and I will turn it over to Dave. And one other comment, sorry Dave, is try to save your questions for the end, write them down. You can put them in the chat if you want to, and we'll kind of go to a facilitated discussion with both speakers at the end.
Okay, great. Thanks, Sarah. Good morning, everybody. So I'm going to kick us off with a discussion of some of the data underlying two therapies for COVID-19 disease, remdesivir and steroids. I put this disclaimer up, essentially telling you that much of what I'm telling you now will probably change in the next, who knows, 3 to 6 months, maybe sooner. But just as a reminder, current treatment guidance really looks nothing like what we struggled to put together, in March of 2020. There's numerous ongoing trials, some of them looking at multiple therapies, including in combination, that are really being conducted extremely rapidly. But right now, anyway, based on the data we have, I would say two therapies have emerged as the mainstays of current COVID-19 treatment: an antiviral, remdesivir, and anti-inflammatory, antifibrotic approach, which would be corticosteroids. And then Dr. Jenkins is going to talk about the third potential therapy in convalescent plasma. So I'm going to start with remdesivir. And just quickly to kind of show you what is remdesivir. So it's a aryl oxyphosphoramidate prodrug. And so this is what is administered intravenously. And it's a prodrug. It has this first phosphate on it, so it's a phosphoramidate, has the first phosphorus, but then this prodrug is meant to keep it stable and hopefully increase the amount that gets into cells. This is the active form that actually gets incorporated by the viral RNA polymerase and acts as a chain terminator. I won't say much more than that. The in vitro data suggests a wide range of potency, ranging from 10 nanomolar in human alveolar epithelial cells, which is about the lowest you'll see. But then it could be 1,000-fold higher, up to 10 micromolar about in other cell lines. That probably has to do with the fact it requires at least 4 different enzymes for activation from this prodrug to the active triphosphate. And that is an area I think we may see some improvements by different prodrugs and hopefully even an oral formulation at some point. So there's a little bit of animal data. This is data in rhesus macaques, where 6 macaques were given, 12 macaques were infected with COVID-19 or SARS-CoV-2, which is the virus, and then followed over the next 7 days. The group that was administered remdesivir, which is here in kind of these red indices, circles in most of the cases, was started on remdesivir within 12 hours. So that's something to keep in mind. But with remdesivir, after 12 hours in these rhesus macaques, they had much less in the way of symptoms from COVID, fever, respiratory distress, dyspnea, where these are the control macaques, which developed a higher clinical symptom score. Their chest x-rays looked much better if they were given remdesivir. And then if you actually looked for virus in BAL, so they quantitated the amount of virus using PCR, actually you couldn't see a significant change in the amount of virus you could detect. The amount of culturable virus or live virus was decreased significantly in BAL. And then if you looked at lung tissue at necropsy, there was less SARS-CoV-2 in the lungs of remdesivir-treated macaques. And then these are just histopathologic sections, and I think you can appreciate the more dense pneumonia in the vehicle-treated side over here as opposed to the remdesivir side over here. So certainly some proof of concept in an animal model. Again, the big caveat here, I think, is they got remdesivir within 12 hours of being infected. So what are the key clinical questions with remdesivir? Make sure I stay on time here. So I think early on there was a little bit of what I put in quotes here as conflicting data. I'll try to run you through the kind of two, again, quote unquote, conflicting studies. I don't think they're necessarily conflicting really. Talk a little bit about timing. I think we presume earlier is better with an antiviral. What about certain patient populations based on severity? And the extremes really, I think, is where there's still some questions. So those with mild COVID-19, in other words, that aren't hypoxic or at least don't require oxygen. And then those that are very ill, who are already intubated or on ECMO. What's the role for remdesivir in those populations? How long should we use it for? Most of the studies have actually looked at 10 days, but we'll talk about 5 versus 10. Of course, is it safe? And then how can it be improved? I've already alluded to these. I won't really touch on them anymore, but it's obviously an IV medication. It would be great to have an oral version. And again, the cellular activation is very complicated and probably could be improved on and probably accounts for some variability. So this is the first randomized controlled trial of remdesivir that was actually published. It came out right about the same time as we heard about the NIH ACT study. I'm not going to cover the compassionate use experience that was reported in the New England Journal of Medicine. I really, frankly, don't think that's a very useful report because it was a compassionate use. So this was a randomized controlled trial, which was blinded and placebo controlled. It was conducted in Wuhan, China, in kind of the tail end of their initial outbreak there. But patients had to have confirmed COVID-19 disease with signs of lower respiratory tract infection. So they had to have infiltrates or hypoxia. Just to already compare this with what we're going to hear about the ACT study, this tended to be an older population. There was a high rate of comorbidity, but it was not a terribly ill population. So less than 1% of this group enrolled in this trial was on mechanical ventilation or on ECMO. There was also, I think, a huge confounder, especially in hindsight, now that we know about the data about steroids, that about 40% were already on steroids before they started in the trial. And 2/3 received steroids during their treatment course with remdesivir. So again, a big confounder here. And then the primary endpoint was a 2-point improvement in this 6-point scale that essentially ranged from death to discharge and not being on oxygen. So this is the main result. It looked at cumulative improvement over 28 days or 4 weeks. And you can see the lines are close. Remdesivir is on top. So they did have some slightly faster improvement or a trend towards faster improvement. You can see the mean time to improvement was 21 days in the remdesivir group and 23 days in the control group. Here's the hazard ratio for improvement, going towards favoring remdesivir, but crossing 1 in terms of the hazard ratio and was not statistically significant. These were the numbers evaluable at the different time points. I'll just highlight the one kind of sidebar. If you looked at those who got into the trial and on therapy at less than 10 days of illness, so relatively early, comparatively, there was a larger difference, more improvement seen with remdesivir, about a 5-day difference in time to improvement, and a larger hazard ratio, though it still did cross 1, so it was not significant. So this came out, caused a lot of kind of, I guess, consternation or question because it was about the same time as we had at least the preliminary press release from the ACT study, which was the large NIH-NIAID study. We participated here at Denver Health with Gabby Frank, one of our hospitalists, being the lead PI. So this was a prospective, again, blinded, placebo-controlled study, looked at remdesivir for 10 days versus placebo. I'll run through the dosing in a bit. These were all hospitalized patients with documented or confirmed COVID-19 disease, and again, signs of lower respiratory tract infection, either hypoxia or infiltrates. They could have either. The primary outcome was improvement in an ordinal scale. Again, this was a scale that went from 1 to 8 now instead of 1 to 6. And you had to improve down to ordinal 1, 2, or 3 up to 28 days was achieving the primary endpoint. There were some secondary endpoints we'll touch on. Again, because this got a lot of press, the original primary endpoint was this, improvement by day 15. That was switched to a secondary endpoint prior to any of the data being seen by the study group after talking with statistics. So this is the population, again, to compare to the Wuhan study. It was a younger population, 58 the mean age, 59 versus 66. A high rate of comorbidities again, although I'll point out obesity, over a third with obesity in the predominantly United States study. There were some international sites. And that was not mentioned in the Chinese study, but presumably more obesity was likely to be found in the US study. And then this is the population enrolled. Again, to compare to the study performed in China, you can see here about a quarter of the population was mechanically ventilated or on ECMO, where again, in the other study, it was less than 1%. So these are the preliminary results. So the recovery risk ratio 1.32 in favor of remdesivir. So patients given remdesivir recovered faster. And this is the range, the 95% confidence interval. And here you can see it graphically. The mean time to improvement to going down to 1 to 3 on that ordinal scale was 11 days with remdesivir versus 15 days with placebo, so a 4-day difference. These are the differences in mortality, and this was done at 14 days because they couldn't look at 28 days in this preliminary report because a number of patients hadn't reached the 28-day point yet, so this may change in the final analysis. But you can see almost a 5% decrease in mortality, but this was not statistically significant. You can see the hazard ratio suggests a lower mortality rate with remdesivir, but again, the confidence interval is relatively large and does cross 1. I just want to take a second, since I alluded to this, and look at so this is the different baseline ordinal groups. So how sick were they when they enrolled into the study and were randomized? Ordinal 4 was hospitalized but not on oxygen. So this is the least sick group. A trend towards maybe improvement faster with remdesivir, but this was not statistically significant. You can see relatively smaller numbers here, so the confidence intervals were wide and overlapping. So this was not statistically significant. The results were really driven by this group, which is hospitalized on supplemental oxygen, but not on high flow oxygen, not mechanically ventilated. So ordinal group 5 had the largest effect and really, it was the largest population in the study and really drove the findings. And then here, ordinal 6, this would be patients hospitalized on high flow oxygen or some type of non-invasive positive pressure ventilation. So heated high flow, CPAP if it was used, something like that. And you can see here again, smaller numbers in this group and not a statistically significant benefit. And then finally, the most severely ill group, mechanically ventilated or on ECMO, no clear difference. And this one really looks almost superimposable from at least the ACT-1 study. This is a forest plot just looking at different groups. I won't go through each one. What you see is that in general, they all tend to at least lean towards the side of benefit with remdesivir for 10 days versus placebo. The only group where it really looks near unity is those receiving mechanical ventilation. And then I want to show this because this was the original planned primary outcome. It was statistically significant. So what you can see is here, the color here is the enrollment score. So these are groups that came in at 5, 6, or 7. And then what this kind of shows is how they evolved over time to day 15. If they moved to the right here, they improved. So these blue groups are discharge groups that are out of the hospital or at least off oxygen. And so you can see after starting here, those that got remdesivir improved more than those that did not get remdesivir. And you see some even worsen, particularly without getting remdesivir. You can see in ordinal group 6, a slight shift towards improvement. And then again, in group 7 that was mechanically ventilated, you see really not much difference in evolution, at least over the first 15 days. So again, I think I've highlighted these just to compare and contrast these two randomized trials. The population was older in the Chinese study, more hypertension, diabetes, and likely much more obesity in the ACT study, which was primarily a US-based study. They had more severe disease. There was a high rate of concomitant steroid use in the Chinese study. There was essentially no steroid use in ACT-1. There are also different primary outcomes. They use different scales. The Chinese are, Wong study was compressed, only a 6-point ordinal scale versus 8 in ACT. And then the Chinese study was stopped early because COVID really tailed off in China, and so it was underpowered. So I want to touch on duration here. I won't say much. There's one randomized trial that looked at duration, 5 versus 10 days. The overall takeaway is that there's no clear difference in 5 versus 10 days. The reason, as you'll see when we come to the recommendations, that they hedge on invasive mechanical ventilation. So everybody got 5 days of remdesivir in this study, right? And then those randomized to 5 stopped, those randomized to 10 continued for another 5 days. So this graph says, where were they at day 5? Coming into this study, they actually excluded mechanical ventilation, but some participants got worse. So at day 5, here's where they were. The 5-day group would have stopped, the 10-day group would have continued. And so in this mechanical ventilation group, you can see there's what looks like a trend towards the 5-day group moving on more to have death or remain mechanically ventilated or be on high flow oxygen. Particularly the death looked like a difference. This was not statistically significant. It looked like a trend. And this is what I think has wound up being in the guidance as a suggestion for groups that are on mechanical ventilation to continue to 10 days, whereas other groups, the IDSA recommends to just do 5. I think in the interest of time, I'll probably skip over this. This is just another study that looked only at critically ill patients. And the moral of the story here, this was in Italy. It did appear with remdesivir in patients who were all already mechanically ventilated, severely ill. This was an older group, that 10 days of remdesivir cut mortality. This was not a randomized study. So there's certainly some concerns about who they would have decided to ask for remdesivir under compassionate use. Maybe severely ill patients that they thought were too far gone, they wouldn't have asked. They did have to survive 24 hours. So I think this is suggestive. It's methodologically a much weaker study, but suggestive in a severely ill population that maybe remdesivir has some benefit. And certainly I think since these patients are so ill, we use remdesivir in this population, but I think how efficacious it is in this group is up to question. So there is an excipient in remdesivir that is the reason it's not routinely recommended in those with end-stage renal disease. All I'll say on this is I think it certainly needs to be noted that it's a relative contraindication. The amount of this excipient cyclodextrin that the patient would be exposed to with a 5 or even a 10-day course of remdesivir is much below what we think the safety threshold is in humans. So I think it's a relative contraindication, and my practice certainly has been to use it in patients with end-stage renal disease. Certainly if they go on to hemodialysis or renal replacement therapy, it is easily hemodialyzed, and I think there probably should be used if they otherwise meet criteria. So these are the current recommendations. It's remdesivir 200 milligrams IV once, then 100 milligrams IV for 5 to 10 days. These are the IDSA recommendations. Essentially, anybody hospitalized that requires supplemental oxygen, it's recommended. And 5 days is recommended for everybody except those who are mechanically ventilated or on ECMO. And then there's an EUA, and I've put the link here so you can get to the EUA documents. This is not an FDA-approved therapy yet, to one of our pre-test questions. It is available under an expanded use authorization or emergency use authorization. So you are supposed to discuss with the patient and provide them a fact sheet, which you have links to here at the download. You should check LFTs daily, and it's not recommended if ALT is above 5 times the upper limit of normal. And again, not recommended in those with creatinine clearance less than 30 unless potential benefit outweighs risk. And as I've said, at least in my opinion, for most patients with severe COVID-19 disease, the benefit does outweigh the risk. So quickly to talk about steroids here in 5 minutes. I put this in here, you can go look at it. This really just set the stage, I think. It was kind of fortuitous. This is not in COVID-19 disease. This is ARDS due to sepsis in most cases, or pneumonia. And this was really one of the first randomized controlled trials to look at steroids, and it showed a significant mortality benefit for dexamethasone. And this came out in March of 2020. Again, this is not COVID-19 disease, but I think it kind of set the stage for us to maybe think a little bit more openly about the possibility of steroids in ARDS. So this is the biggest trial, and probably the one we really need to cover, is the recovery trial done at the UK national health sites across the country. So they enrolled a tremendous number of patients in a very fast time period. You can see here over 6,000 patients randomized 2-to-1 to standard of care. So 2 times as many got usual care, which typically did not include steroids, at least not early. And then 2,000 got dexamethasone. The dosing was 6 milligrams of dexamethasone, either oral or IV, for 10 days. Only continued till they were discharged, so it was not continued at discharge. And there were really no exclusions. They enrolled everybody, unless the investigator for some reason thought they shouldn't get steroids. And the only outcome, the primary outcome, was 28-day mortality. This was really a masterpiece in simplicity in doing this study. They only had one follow-up sheet that was filled out at 28 days to assess status. And they looked at some subgroups. They also looked at time to discharge and progression from where they started to mechanical ventilation. You can see here, 8% got dexamethasone in the control group, where it was over 96% got dexamethasone in the intervention group. And then in the intervention group, they also got dexamethasone within the first 2 days, whereas those that used it as standard of care tended to get it later in their course. So here's the overall findings for all participants. A decrease in mortality that was statistically significant, 23% with dexamethasone, 25.7, so about a 3% decrease in, absolute decrease in mortality overall. I just want to show you the mechanical ventilation group, where there was actually quite a large decrease in mortality, about a 40% relative decrease. So 29% mortality in the dexamethasone group, 40% mortality in the usual care group. So that's about a 33% relative reduction, absolute reduction again, about 12% in the dexamethasone group. So that's a dramatic decrease in mortality. They looked at, this is important because those who came in who were ventilated or required oxygen therapy seemed to clearly have a benefit. In contrast, those who didn't require oxygen for their COVID-19 did not have a benefit, and there was even a trend towards potential harm. So I think this is important as we talk about which population it should be used in. And again, the risk of progression, so if they didn't come in and didn't need to be mechanically ventilated right away, dexamethasone seemed to prevent them from going on to need mechanical ventilation. This is a second study done in Brazil in ICUs. This was only in intubated patients. They used a different dose of dexamethasone. They got on within 48 hours. I won't go through it more than that, just to say they seem to have higher number of ventilator-free days. So about 6.5 days off the vent here, 4 days if you didn't get dexamethasone. Again, there was some steroid use in the standard of care group. They didn't see a significant difference in mortality, a small trend. So these are the recommendations for steroids: dexamethasone 6 milligrams IV or PO once a day for 10 days or until discharge. Again, if they're discharged, they're typically not sent out on steroids, or that's not the recommendation. And it should be those with severe COVID-19, really defined as having hypoxemia and requiring supplemental oxygen. So again, in that population, if they have to be admitted for COVID-19 because of fatigue, dehydration, they can't care for themselves, but they're not hypoxic requiring supplemental oxygen, the recommendation is not to use dexamethasone, again, because in the recovery trial, there was a signal that those patients actually may be harmed by giving dexamethasone. And that's covered right here. And here's a link to the ID practice guidelines, which cover all the COVID-19 therapies, remdesivir, dexamethasone, as well as some that we don't use now, including hydroxychloroquine, lopinavir, ritonavir. They're all here at this link. So in summary, we have accumulating data that both remdesivir and dexamethasone should be used in severe COVID-19. Most hospitalized patients should be treated with both. So if you're starting one, you probably should at least think very hard about, should I be starting the other one? And they certainly seem to have a shortened time to recovery, decreased mortality in select populations, particularly for dexamethasone, decreased progression and mortality in severely ill patients. 5 days is adequate for remdesivir for most patients, and both appear safe. Okay, I think I got through that close to on time. Let me stop sharing and see. You have questions, Sarah, or are we going to go on?
Thanks, Dave. We're going to save questions for after the next presentation.
Okay.
Thank you very much for the excellent presentation. That was a lot of information in a short time. Well done. And our next presenter is Dr. Tim Jenkins. He's Associate Professor of Medicine in the Division of Infectious Disease and Infectious Disease Faculty here at Denver Health. And he will be talking about the role of convalescent plasma. So I will mute and turn it over to Tim.
Thanks, Sarah. Can you guys hear me and see my screen?
Yes.
Great. So I'll just start with a quick review. So convalescent plasma is plasma, or the liquid portion of the blood that contains antibodies from patients who have recovered from COVID-19. So typically within the last 2 to 8 weeks that they've recovered. And this plasma contains antibodies to the SARS-CoV-2 virus. So if we transfuse this convalescent plasma to patients who have either been exposed to or have infection with the SARS-CoV-2 virus, those antibodies can then neutralize the virus and either, number one, protect from infection. So this would be if it's being used in a post-exposure prophylaxis setting to try and prevent infection, or if infection is established, prevent or mitigate progression of that existing infection. So that would be used more in a treatment setting. And the vast majority of use of convalescent plasma and the data for this are with respect to treatment rather than post-exposure prophylaxis. So that's what we'll focus on today. And I'll just start out with some of the limitations and caveats of this literature in this talk. So first of all, the vast majority of data that we have comes from observational studies rather than randomized trials. There are a few randomized trials that have been published, but they are small in size and so therefore underpowered with respect to their primary and secondary outcomes. Next, not all of these studies have been peer-reviewed, so a number of these are preprints posted on a preprint server. So in my references, if you see the word preprint, just know that that's not a peer-reviewed publication. There's been a substantial amount of heterogeneity of the patients that have received plasma in these studies. So with respect to severity of illness, timing of when they receive the plasma, and then the treatment itself. So the volume of plasma and antibody titers, which makes it somewhat difficult to interpret this literature. And then lastly, similar as Dr. Wiles mentioned with respect to remdesivir and dexamethasone, this is really a rapidly emerging literature and things are changing quickly. So when I searched on clinicaltrials.gov last week for convalescent plasma and COVID-19, I found 153 trials that were registered, and the vast majority of those were listed as active and recruiting. So we're going to have really a tremendous amount of literature in the coming months and years on this topic. So in early April of this year, the FDA, in combination with investigators from the Mayo Clinic, established the National Expanded Access Program. So this program was a multi-center, open label program, really just designed to provide access to the treatment of convalescent plasma and to evaluate its safety and effectiveness. So to be eligible for this program, patients had to be at least 18 years old. They had to be hospitalized with confirmed SARS-CoV-2 infection, and then either have severe or life-threatening COVID-19 disease or be judged by the provider to be at high risk for progression to disease. So very broad eligibility criteria to be able to get plasma under this expanded access program. And the investigators had a pre-specified plan to evaluate the efficacy of this by creating a control comparator group, and we'll talk a little bit about that as we get further in the talk. So this is participation in this National Expanded Access program. So you can see on this US map, the yellow dots actually represent the number of hospitals registered per city. So the larger the dot, the more hospitals. And then the green shading represents the volume or the number of patients that have been enrolled and received plasma under this program. So you can see that in our mountain region, we've had relatively fewer hospitals and relatively fewer patients who have received plasma as compared to some of the other more populous states like California, Texas, Florida, and of course the Northeast and upper Midwest. This represents over 70,000 patients that have so far received convalescent plasma under this National Expanded Access Program. And many other patients have received plasma outside of this program as well. So this has really been quite widely used. At the peak, we were administering about over 800 transfusions per day to patients with COVID-19. So who have we been giving this to? So this was a publication on the National Expanded Access Program of the first 20,000 patients enrolled in this program that received plasma. So 60% of the patients were at least 60 years old, so tended to be older patients getting this. Over 60% were male. 20% were Black and 5% were Asian, and then 35% were Hispanic or Latino. So fairly diverse from a racial and ethnic perspective, which really, I think, represents the epidemiology of this pandemic in the United States. If you look at this table, this sort of describes the severity of illness. So if we look at the total column here of these 20,000 patients, you can see that over 70% had current severe life-threatening COVID-19 at the time that they were transfused, whereas almost 30% were judged to be high risk of progression to severe life-threatening disease. You can also see that between April and May, this actually changed. So a higher proportion in May of the patients that received this had high risk for progression. A smaller number of patients were in the ICU, and a smaller proportion of patients were mechanically ventilated. So you can see that the population that we were giving this to over time shifted to a less critically ill population, probably based on the rationale that this is thought to be more effective earlier in the course of illness, and we'll talk a little bit more about that. So this is some safety data from that first 20,000 patients that received plasma in the expanded access program. We'll focus on these two columns. So these were the adverse events, transfusion reactions, or 7-day adverse events that were judged to be related to the plasma infusion. And this is the percent of cases where that event occurred. And you can see that for transfusion-related reactions, so mortality, transfusion-associated cardiac overload, transfusion-associated lung injury, and severe allergic reactions, the numbers are all pretty small and the percentages are quite low. So on average, on the order of 1 to 2 out of 1 per 2,000 administrations of plasma, so quite low. And then 7-day serious adverse events were also fairly low. So thrombotic complications, hypotension, and cardiac events were all less than 0.5% in terms of frequency. So based on these data, it's thought that the administration of convalescent plasma is in general relatively safe, with the caveats being that this is not randomized data. This is just a large group where everybody got plasma. So we really don't know with certainty about the frequency of these adverse events compared to patients that don't receive plasma. And also this was dependent on reporting from investigators, and so there could be underreporting playing into this. So they also used the expanded access program to look at outcome data. So this shows mortality after plasma infusion stratified by antibody titer of the plasma and by time to infusion. And this is a little bit complicated, so I'll walk you through this. So the y-axis here is 7-day mortality, so the percent of patients that died. These bars represent patients who received low antibody titer plasma, medium titer, or high titer plasma. And then this group of bars is the patients that received plasma within 3 days of diagnosis. This group is the group that received plasma at 4 days or after from diagnosis. And you can see off the bat that there's an apparent trend towards reduction in mortality with higher titer plasma, higher antibody titer plasma. And you can also see that compared with giving it later, the patients that got it earlier within 3 days had a relatively lower mortality rate. So 7% with high titer plasma given within 3 days versus 10.5% mortality with high titer plasma given at least 4 days after diagnosis. So suggestive, but certainly doesn't prove that giving it earlier and giving high titer plasma improves clinical outcomes. So again, this is all observational data in which all patients received convalescent plasma. So a number of limitations to that study approach. So randomized trials, really the gold standard. There have been 4 that have been published now, at least in preprint form. A couple have been published in peer-reviewed journals. And I'll just focus on this one, which was the first that was published in JAMA. And this was an open label randomized trial that was performed in Wuhan, China in 7 centers. They were shooting to enroll 200 patients who had severe life-threatening disease, but unfortunately had to terminate the study after only 103 patients were enrolled. So they only hit about 50% of enrollment because the epidemic died out and they had no further cases to enroll. Their primary endpoint in this study was clinical improvement at 28 days. And this was again based on one of these ordinal scales ranging from hospital discharge to death. And they had a number of secondary endpoints, key secondary endpoints, which I'll talk about on the next slide. So this is a summary of those key primary and secondary outcomes. So you can see that 52 patients received standard of care plus plasma. 51% of patients received standard of care only. So this was the control group. And I should note that a number of these patients, the vast majority were receiving antivirals, and many were receiving corticosteroids as well. You can see that for their primary endpoint, There was a higher rate of clinical improvement, 52% versus 43% with convalescent plasma, but that was not statistically significant. Similarly, non-significant changes in the hospital discharge rate at 28 days, so 51% versus 36%, and a lower mortality rate, 15.7% versus 24%, but again, not statistically significant. There was a substantial and statistically significant difference in the proportion of patients that had cleared the virus by 3 days after infusion, so 87% versus 37.5%. So although this study was a little bit disappointing and that it was underpowered, I think you can see from these numbers that the data really seemed to favor convalescent plasma over standard of care, even though it didn't prove improvement in clinical outcomes. So this was data from a meta-analysis that was put together, looking at both randomized controlled trials and other matched controlled trials. I'll just focus on the randomized trials. So this included 3 of the 4 studies that have been published to date. The 4th one was just published about 2 weeks ago. So these are the 3 randomized controlled trials. Anything left of the odds ratio of 1 here suggests that convalescent plasma improved mortality, and these are the point estimates. And you can see that the point estimates all favored convalescent plasma in these 3 randomized trials, but they had very wide confidence intervals that crossed the odds ratio of 1. But when we looked at together, the point estimate was about 0.45, so about a 55% reduction in the odds of death in those that received convalescent plasma versus those that did not. And this actually was statistically significant. So this represented about a 13% mortality rate in the plasma group and about a 26% mortality group in the standard of care group. So again, suggestive but not proof, because this is a meta-analysis, that plasma may improve clinical outcomes. So based on this National Expanded Access Program data and the randomized trials that were published, the FDA actually approved emergency use authorization of convalescent plasma in late August. So similar to remdesivir, as Dr. Wiles mentioned, this is not an FDA approval, but given the public health crisis of the pandemic, it allows for emergency use of convalescent plasma. And it's specified that this is related to hospitalized patients with COVID-19, so not outpatients, and specifically either intubated or non-intubated patients. So based on the data that we showed, they recommended use of high titer convalescent plasma, and then treatment prior to intubation and within 3 days if possible. So early treatment when this can be given. The dose that they recommend is a single unit, which is about 200 cc's, but they do allow for giving additional units based on clinical judgment and clinical status of the patient. So how do you give convalescent plasma under this FDA emergency use authorization? So first of all, you need to be in contact with your blood bank and make sure that they can source plasma from some of these central blood banks that are collecting convalescent plasma. You then need to discuss the fact that this is investigational in nature and not approved therapy, as well as the potential risks and benefits and alternatives with the patient or their proxy if they're not able to have that discussion. You need to provide the fact sheet that's provided by the FDA that really lays out these risks and benefits nicely to the patient. And there's also a fact sheet for providers that should go to providers at your institution. And then I think it's certainly best practice to document that consent process in the medical record. And then, of course, you also need to follow institutional protocols for giving blood products to patients. So at Denver Health, we have a separate consent form for blood and blood products transfusions that we would complete. And then finally, you have to monitor for and report serious adverse events or deaths that are potentially attributable to the convalescent plasma to the FDA. And there's a standardized reporting form if one of those should happen. And I have provided links for you down here to the emergency use authorization document plus these FDA fact sheets if you're interested in these. So I just want to highlight that this really is still not considered standard of care. So in fact, the Infectious Diseases Society of America COVID treatment guidelines panel recommends the use of convalescent plasma only in the context of a clinical trial, stating that there's still a knowledge gap with respect to this particular treatment. The National Institutes of Health COVID treatment guidelines panel states that there's insufficient data at this point to recommend either for or against the use of convalescent plasma one way or the other. So I think these guidelines really highlight the fact that there are still a number of unanswered questions respect to this therapy. So when we have adequately powered randomized trials, will this be safe, and does it improve outcomes, in particular mortality, compared with standard of care? And standard of care, as Dr. Wiles mentioned, really has become corticosteroids and remdesivir. So I think an important question is, what is the incremental benefit over those two agents, over steroids and remdesivir, if any? Is there any incremental benefit over those agents? In what patient population should this be used? So should it only be used in non-intubated patients? Is it okay to use it in patients who are critically ill on the vent or on ECMO? What about children, pregnant women? So lots of questions regarding appropriate patient populations. What's the optimal timing? Does it have to be given within 3 days or early on in the course? Or is it still effective later in the course? And then similarly, what are the necessary antibody titers in the plasma? And what's the optimal volume? Is a single unit, as the FDA is recommending now, appropriate, or do we would higher volumes be potentially more effective? So numerous unanswered questions. And I think the good news is, as I mentioned, there's so much, there are so many trials that are in process now that I think we will have answers to many of these questions. And in the last couple slides, I'll just highlight a couple of the big trials that are ongoing. So the first is an NIH-funded study called the Pass It On trial. So this is one of 2 large randomized trials being carried out in the inpatient setting in the US that are being funded by the NIH to the tune of around $45 million. And these are part of the Operation Warp Speed program of the current administration. So this will involve over 50 hospitals, and we'll be recruiting adults who are hospitalized with COVID-19. And these patients will get either convalescent plasma or placebo, which is going to be a lactated ringers plus a multivitamin solution. And then the primary outcome will be their clinical status at day 15 after transfusion by this COVID ordinal outcome scale. So again, ranging from discharge with no functional limitations all the way to death. The original sample size was going to be 500 patients, but they actually recently expanded this to 1,000 patients. And according to the website, this is supposed to be completed in April of 2021. So a very aggressive timeline with this, and that would be fantastic if we had the data by then, but we'll see if they can actually accomplish this. The other randomized trial I wanted to point out that I just thought was interesting, that Denver Health is participating in, or I think hopes to participate in, is the C3PO study. So this is an outpatient-based study, so that will be carried out in 50 emergency departments across the US. So these are, this will recruit adults who present to the ED with just mild symptomatic COVID, but who have risk factors for progression to severe disease, but who are also clinically stable for outpatient management. So they'll either receive a dose of convalescent plasma or placebo. So this is saline plus a multivitamin in this study, and they'll be discharged home. And then the primary outcome will be whether there's evidence of disease progression at 15 days. So did patients require admission to the hospital, or did they die within that 15-day time window? And the sample size for this study is 600 patients. And on the website, they report that the estimated completion date isn't until December of 2022 for this study. So a much longer anticipated timeline for this study. So we'll see how that goes. So certainly hopeful that some of these large randomized trials will start to answer some of these questions. So I'll just summarize with the fact that our current clinical data, I think, are clearly fairly suggestive, but not definitive proof that convalescent plasma is safe and may improve outcomes. Hospitals can now be administering this under the FDA's emergency use authorization. And I should note that the National Expanded Access Program has now been closed down. So that's no longer an option to give this. It would have to be under the FDA emergency use authorization. And then finally, adequately powered randomized trials are really necessary to better understand the safety and efficacy of this in various populations. And so hopefully we'll have more data as this goes along. And in the last 30 seconds, I'll just kind of give you Denver Health's approach to use of this product. So right now, the vast majority of our patients who are admitted to the hospital who are hypoxemic are getting started on dexamethasone and remdesivir up front. We're then screening them for involvement in a couple of our ongoing randomized trials, the next remdesivir trial we're involved with, and also a monoclonal antibody randomized trials. So if the patients are interested or eligible for those studies and they're not improving or having progression of disease on the dexamethasone and remdesivir, that's when we tend to be offering convalescent plasma at this point. So we've given convalescent plasma to about 25 patients total at Denver Health since the pandemic started. So thanks for your attention. I'm happy to stop there, and we'll turn it back over to Sarah.
Okay, thanks, Tim. I was very interested to hear that there's a C3PO study. I'm wondering if the whole suite of studies will be Star Wars themed, including R2-D2 and BB-8 in the follow-ups. In the Hep C world, we like to see themes in our studies, so C3PO being the beginning of some memorable study names. So I would like to open it up to everyone, and I noticed that a handful more participants have joined since the very beginning, so if you are new or if you joined midway through, please put your just your city where you're coming in from in the chat box. It's helpful for us to know kind of the range of where our participants are. And feel free to unmute yourself and speak up and ask a question, or put a question in the chat box. And I'll just give it a second. And just to kind of start things off, Dave, we have a question about an oral formulation, if that's in the works for remdesivir.
Yeah, so it is, or at least there are some groups working on it. I don't know about big pharmaceutical companies, but to give a shout out to Chip Schooley and the group at UCSD, they're working on an oral formulation that uses a prodrug formulation. I don't know if any of you remember brincidofovir, that oral formulation of cidofovir that was studied. So it's the same process. It essentially puts a long lipid tail on it as a prodrug so it can go into lipid membrane. So yes, there are some people working on it. And again, it appears that actually the prodrug choice probably wasn't the best one, because it does appear that it's not activated in all cell types equally, and some can be really, some cell types or tissues don't activate remdesivir very well. But yeah, so it's in the works, but I don't know of anything that's imminent, that's for sure.
Anyone else with a question about any of the medications or treatment options we discussed?
Tim, I've got a question for you. So the titering, how does it really work? In other words, is it just the amount of antibody that recognizes COVID, or do they actually have a certain threshold for also neutralization? Is titering take into account both those things, just the amount of antibody present and how well it neutralizes, or is it one or the other?
Yeah, so it's a good question. In the FDA emergency use authorization, they recommended use of a particular antibody test, the orthovitros IgG, and that's a group of IgG antibodies. So not necessarily neutralizing antibodies, but it has been shown that a titer of overall IgG antibodies does correlate with neutralizing antibodies. So just for the group, the difference between neutralizing antibodies and non-neutralizing antibodies. Neutralizing antibodies bind the virus often to the spike protein, and by that binding alone, it disallows entry of the virus into the cell, or it signals opsonization of that virus. So it clears the virus on its own. Other types of antibodies, non-neutralizing antibodies, might bind to different locations on the spike protein, but they don't necessarily prevent it from entering the cell. So it recognizes it, and it may signal other pathways to try and clear the virus, but on its own, these non-neutralizing antibodies don't prevent cell entry.
I see a question here from Karen. Yes, so she asks about if there's a plan to evaluate remdesivir with dexamethasone in a study, and how many people in the recovery trial got dexamethasone. So 5 in the recovery trial got dexamethasone out of over 6,000. I think there were 3 in the Decadron group and 2 in the standard of care group. So not significant amount of remdesivir use there. So yeah, there are some plans or potential plans. As I alluded to, there's so many trials going on, but one of the potential iterations of the ACT study would be something to come back and look at remdesivir with dexamethasone. There are some other combinations they're evaluating as well, but yeah, there are some plans in work. I'm not aware of anything that's open yet looking at the combination though.
Dave, I have a question about just kind of something that comes up on the wards. For folks with diabetes, people seem to be kind of hesitant to start dexamethasone. Is there any data about the benefit versus risk for someone who's diabetic?
You know, in the recovery trial, and I kind of alluded to the cyclodextran safety, but I didn't really talk overall. Overall, I mean, both for remdesivir and steroids, they've looked very safe. And in the recovery trial, they didn't see any actual evidence in the trial that there was worse control of diabetes, maybe almost counterintuitively. So I think it appears safe, and I think particularly given the mortality benefit, you know, certainly in the ICU, I think if you have somebody mechanically ventilated, it should be pretty much a no-brainer. But you're right, we do hear like from our hospitalist colleagues or internal medicine that they're a little hesitant, and somebody, if they're already a poorly controlled diabetic, to use dexamethasone. I think given the mortality benefit, I think it should be used, and again, the trial data don't suggest that there's really adverse glucose control using it.
I'm going to give it a second. If any of our new participants have any questions, just got a couple minutes left. Okay, I don't see anyone unmuting, so I'm guessing that's a no. But hopefully we'll have a little more time and a little more questions in the coming sessions. But I really appreciate everyone tuning in today. Victoria has a couple closing comments, and then we'll wrap it up.
Thanks, Sarah, and thanks to our presenters and Sarah and Karen and everybody for tuning in and helping facilitate this session today. I want to remind everybody from the email you got, we do have a resource library, so the presentations will be uploaded. This recording will be uploaded once it gets processed. So that's in the chat box. I just posted that link. The second link is for our evaluation. You'll get that every 2 weeks should you join. And I'll also email it out to you for convenience, but we would love for you to take that survey. It shouldn't take any more than 5 minutes. Not only is it to evaluate how we did today, but it's also to ask you about future topics you want to hear about. So if there's something you're really itching to learn more about, let us know in there, and then we can work it into our planning. And also, if you want to present on a topic or you know a great speaker for something, you can also let us know in that same link. But we will be back in 2 weeks on October 13th, the same time, so 7:30 a.m. Mountain Time and 8:30 a.m. Central Time. We'll have 2 more speakers. They'll be discussing pulmonary pathophysiology and respiratory management of COVID-19 patients. I put my email in their chat box and Caroline as well. You can reach out to either of us or both of us with any extra questions that you may think of, or if there's anything you want to know about for the next session, you can send your questions in now if you're already thinking about them. But we are happy to have you all here and very thankful for you to join in an early morning session.